can
Yes, sir.
start.
We can start, right? It's
Okay.
1:05 p.m.
Yeah. So good noon, everyone. So I'll be presenting an journal club paper on efficacy and safety of anti-BCMA CAR-T, the treatment of relapsed and refractory AL amyloidosis. This was published in Journal of Clinical Oncology. And as a part of this CAR-T cell therapy JC series, today we'll be seeing on CAR-T cell therapy in AL amyloidosis. So the article goes like this. So it describes the unmet needs in systemic AL amyloidosis, and it tells about the manufacturing of its product HB-I-0101 and the dose and the trial design. Also, it talks about the patient cohort and baseline frailty, efficacy in terms of hematological, MRD, as well as organ responses. So this will be a little bit different than other. In addition to others, we have an organ response assessment in this AL amyloidosis. And apart from that, there is toxicity profile, and also the article discusses the studies length and limitations and future impact. So, and to set the context, AL amyloidosis is a clonal plasma cell disorder which produces misfolded light chains and they deposit in multiple organs. And the commonly deposited organs are uh, heart, kidney, and also GI. So, skin as well. So, cardiac involvement drives early mortality. And in this case, the article says that even if we stop the production of light chains, the already deposited light chains will take longer time to clear. So, this delays the organ response while the hematological response may be achieved early. So, this article says that we need a deeper rapid hematological response so that the facilitation of clearance of the light chains will be made, and this will help with the organ response. And standard treatment is mirrored from myeloma as if we don't have a separate treatment for AL amyloidosis, and the outcomes are poor, and often patients require multiple lines. So anti-BCMA CAR-T shows unprecedented depth in multiple myeloma, but the data in AL amyloidosis is scarce. So there are additionally safety concerns, which include frailty of the patients and also advanced cardiac disease. And also in AL amyloidosis, there is relatively lower BCMA expression as compared to multiple myeloma. So the rationale for HBI-0101, so this is an academic second generation anti-BCMA CAR-T with 4-1BB co-stimulatory domain, and it was done on 8 to 10 day on-site manufacturing. So they are already conducted a phase one cohort with multiple myeloma to demonstrate the feasibility, and this phase one study demonstrated higher overall response rate. So the study hypothesized that rapid deep clearance of light chains will facilitate early organ recovery in AL amyloidosis. So the trial's aim was to establish efficacy, safety, and also in heavily treated frail AL amyloidosis patients. So the study was a single arm phase one, 1A, 1B trial at Hadassah Medical Center, Jerusalem. And the lymphodepletion used was fludarabine cyclophosphamide, and bendamustine was used if creatinine clearance was less than 30 ml per minute. And they fixed a target dose of 800 million CAR T cells, 18 to 10 to the power 8 CAR T cells, and the range was 5.7 to 10.5. And additionally, from the deliberate inclusion criteria, they included two more patients on compassionate use, and one of the patient had MDS along with AL amyloidosis, and the other patient had ECOG 4 performance status. And for high-risk cardiac patients, the product was given in ICCU with monitoring until the patient came out of acute toxicity. And the key eligibility criteria was more than three prior lines, including a proteasome inhibitor, immunomodulatory drug, and an anti-CD38 antibody, daratumumab. And ECOG was less than 2 performance status. And as I said, there was one compassionate patient with ECOG 4. And the platelet cutoff they kept at more than 30,000. left ventricular ejection fraction more than 40, and creatinine clearance more than 20. And they permitted all myocardial stages of amyloidosis. So there were totally 16 patients enrolled, and 16 patients were leucophorus, and there were no manufacturing failures. So all 16 patients were infused with the product, and the follow-up was more than 4 months for all patients. So the key patient characteristics, the median age was 64 during the study, and median prior lines of therapy were 4, and 88% of the patients were triple class refractory to IMiD CD38 as well as proteasome inhibitor. And interestingly, 38% of the patients had received belantamab, which is an anti-BCMA antibody drug conjugate. And disease burden, cardiac involvement was seen in 81% of the patients, among which there were 31% were advanced Mayo stage, and 38% had advanced NA in New York Heart Association class 3 or 4. And ECOG performance status was 0 to 1 in 75% of the patients, or uh, more than 2 in 25% of the patients. Actually, it is less than 2 in 25%, 1 to 2. And the manufacturing and product, uh, autologous leukapheresis was conducted, and the turnaround time was 8 to 10 days. And the median dose infused was 18 to 10 to the power 8 CAR T cells. They had no dose per kilogram, a fixed dose of 800 million. And they used two sets, and they infused the first 8 patients with fresh product after formulation. So it was stored in 2.5% human albumin and saline. Whereas for the second 8 patients, they had cryopreserved and then they infused. So since there was 8 to 10 days turnaround, all patients except one didn't require bridging therapy. So only one patient had a longer vein to vein time of 82 days. So the patient was given venetoclax for bridging. And for lymphodepletion, the fludarabine cyclophosphamide was used in 13 out of 16 patients, and bendamustine was used in 3 patients. So the endpoints, the primary endpoint, actually to say this 16 patients of AL amyloidosis was a sub cohort, or a single cohort of the bigger study. So the bigger study was of multiple myeloma, and these 16 patients were a cohort. And then they published this cohort as a separate paper. So for the primary endpoint was safety and feasibility of infusion. The secondary endpoints were the efficacy points, overall hematological response, MRD, and organ response, and then survival like EFS and OS, and CAR-T expansion and persistence kinetics. So coming to efficacy, hematological efficacy, the overall response rate was 94%. 15 out of 16 patients responded, and 12 among them were able to achieve complete remission. And remaining three, two had VGPR and one had partial response. So the median time to first response, or first more than PR response, was 10 days, and the median time to best response was 17 days. I'll be showing a swimmer plot. It depicts this better. And MRD negativity was achievable in 64% of the patients, and 54% of the patients at day 130 maintained MRD negativity. So organ responses. So overall, any organ response was 8 out of 13 patients. 62% of the patients had any organ response. Cardiac response was better. So at most of 9 evaluable patients, 7 patients achieved a cardiac response. And renal and hepatic response was relatively poor. So and with cardiac response, people had more than one class of NYHA class improvement. And the median organ response onset was less than 3 months. They achieved better organ response within less 3 months. So when it comes to survival, the median follow-up duration was 8.4 months, and then median event-free survival was 9.6 months, and the median OS was 10 months. So the most of the deaths, early deaths, were concentrated around Mayo stage 3 cardiac and NYHA stage class 4 cardiac patients. And there was no treatment related deaths, but during the follow-up, there were 7 deaths. So four deaths were due to in cardiac patients with cardiac involvement due to relapse, and one patient who was in VGPR, a very good partial response, died of cardiac failure, and there was one COVID-related death. The patient was in complete remission, and one other cause the study hasn't mentioned what cause it is happened in a patient who was in complete remission. And to summarize, the overall response rate was 94% with 75% CR rate, 12 out of 16 patients, and 64% of them achieved MRD negativity. So the time to best response was 17 days, and cardiac response was better among them, and 7 out of 9 patients achieved. So the overall survival was 10 months. So in this swimmer plot, all these indigo lines or the indigo plots are of complete remission, and many patients had complete remission, 12 out of 16. And if we see the red dot, uh, they are they mean death during remission, VGPR or CR. And the light blue lines, they were the time to first evaluation, and many patients had achieved CR or VGPR during first evaluation itself. And regarding safety, so CRS was seen in many patients, 88%, 14 out of 16, while grade 3 was seen in only 3 patients. So they used tocilizumab for 86% of the CRS cases, and they used steroids less in 3 patients only. So the median onset of CRS was on day 1, and it lasted for a median of 2 days. There was no ICANS, atypical ICANS, or any other neurotoxicity. So other adverse events, hematological adverse events were very common, and grade 4 lymphopenia was seen in 100% all of the patients, and neutropenia in 63% of the patients, grade 3 to 4, and anemia in 31% of the patients. So hypogammaglobulinemia was persistent in all patients, and early infections were seen in 56%, and most of them had febrile neutropenia. And late infections included two COVID-19 pneumonias, and one of them expired when he was in complete response still. And cardiac failure occurred in 3 patients, acute kidney injury in 4 patients. Actually, these are organ decompensations occurring during the treatment period, and the study claims that all of these were reversible, and there were no treatment-related deaths. So the CRS was high, 88% with no ICANS, and hematological toxicity and hypogammaglobulinemia was prominent, and there was no treatment-related mortality. So when it comes to CAR-T kinetics, so actually it is in the C, the third diagram. So peak expansion was around 14 days, and the median persistence was for around for 2 months, so 55 days. And uh, there were, if we see the B and C plot, so So if we start with the D curve, so the amount of CAR T cells present per ml was higher in the CR patients with complete remission than with the non-CR with the graph, but the p-value was not significant. Again, if we come to this B diagram, the baseline, as we saw earlier, the baseline BCMA expression is relatively lesser in AL amyloidosis compared to multiple myeloma. So they checked whether this could predict anything, any response. So there was no statistically significant difference in baseline BCMA expression in patients who achieved CR versus who didn't. So this was to compare this CAR-T product with an existing one, ID cell. So the overall response rate was better, and the CR rate was also better with more CRS, less ICANS, and the median overall survival was relatively lesser in our arm. But to be cautious, the patient characteristics were totally different in these two trials. But just as a reference, this trial was compared. So the strength of the study it was the largest prospective AN cohort with CAR-T today, and rapid manufacturing was there, and there was no production failures, and the higher overall response rate and early organ responses in an ultra-refractory setting. So the toxicity is manageable despite cardiac failure, and there was zero ICANS. So, and also they had included two real-world cases, and they provide an I mean, they're two compassionate basis cases. They provided real world experience. So the limitations were it was a single center study and the smaller sample size of 16. And the median follow-up was shorter, 8 months, and there was no control arm. And one another big major limitation is the survival is not just influenced by the disease, but also by the end organ damage or the organ involvement. In our case, the cardiac staging. And also they included two non-protocol patients that may skew safety signals and also maybe potential selection bias. So clinical implications. So this study demonstrates the feasibility of CAR-T in frail AL population, AL amyloid population, and supports earlier reference before end-stage cardiac disease. And also the study had done something. So they had infused the product in ICCU in view of cardiac uh, involvement. So that is one good point. And it also encourages local manufacturing and access and cost. And a multicentric phase two is on way in future directions. So if if this becomes feasible, BCMA CAR-T may be incorporated earlier to maximize organ salvage. And for consolidation of this, so we can use CAR-T with bispecific combinations or to increase the depth and durability, we can use that. We can also use risk-adapted lymphodepletion to reduce cytopenias. In this case, there was persistent hypogammaglobulinemia and cytopenias. And real-world registries can capture outcomes in community settings. So still the study has some unanswered questions. So they had chosen 800 million as an optimal dose, and uh, they had given the same dose for AL amyloid as well as multiple myeloma. And why they chose a fixed dose, they have not mentioned. The rationale is not mentioned. And and the cardiac screening, as we saw before, the cardiac status was a major determinant of survival rather than the actual product or the disease itself. So can we stratify based on that? And regarding organ recovery, so we have conventional chemotherapies have endpoints to describe them, but does CAR-T require different endpoints, or we can use the conventional endpoints? And should if patients are getting MRD negative, what to do further? It's an haunting question always with CAR-T, whether we should consolidate further or should we stop the therapy. And there was 38% of the people who received belantamab, so which is an anti-BCMA antibody drug conjugate. So what happened to that people? It is not separately analyzed. So these questions are remaining. So the take-home message is HBI0101 achieved higher overall response rate and CR in heavily pre-treated patients with acceptable toxicity. And cardiac stage drives mortality, so we have to be careful regarding that when we are giving CAR T cell therapy. And it provides a strong rationale, or it provides the concept that we can still use CAR T cell therapy in AL amyloidosis, and it may redefine the therapeutic landscape. Thank you. Any questions?